Hi, Dr. Abhay, meeting is over?
No, no, last time is finished. Again, new join. Everybody will join.
Okay. So should I cut or continue?
Hi.
Same link, no?
Same link.
So I don't have to cut, no?
No need. Just you
Oh, okay.
mention in group same link.
I pressed on that only. Okay.
Just send a message same link.
Okay.
First hematuria 2 to 3 week. Then BP control 3 to 4 week. Then C3 level become normal 8 to 10 week. Yeah. And C3 10 to then proteinuria na proteinuria for 6 months and microscopic hematuria here for 12 months. Okay, so this is follow-up. Okay, so indication for referred. So 10 indication for refer. Okay. So you can repeat, Dr. Moriam or Rebecca, this one. When to refer.
Okay, when to refer, I will read out to you because I didn't attend when you discussed.
Okay.
Indication for referral are significant proteinuria when UPCR is more than 200.
Milligram.
Okay. Then, I think in that same thing, we can think about microscopic hematuria more than 2 years and macroscopic hematuria more than 2 weeks.
Hmm.
Micro for more than macro means more than 2 weeks.
Micro
Micro
is more than 2 years.
small micro, but more duration, more 2 years.
Uh,
Macro, and you don't wait for long, just 2 weeks. So, proteinuria and hematuria criteria, and one more under proteinuria is a persistent that is more than 50 for more than 6 weeks. So
hmm.
we have two proteinuria and two hematuria criteria.
Yeah.
Then then there is family history. Okay, before we go to family, let's finish the patient's thing itself.
Mhm.
Then is oliguria or acute AKI. If there is AKI, then immediately we have to refer. There is hypertension. Hypertension is coming in the criteria, or is it in only the complication for AGN?
It is a complication, hypertensive crisis.
Okay, so then if there is any complication like AKI,
Hmm.
hypertension, then we have to. Then low C3 for more than 8 weeks. That means it is like other SLE, no? That is what we have to think of, no? What were the DDs if persistent low C3?
DD here is low C3, SLE, messenger proliferative, FPGN.
Shunt. We discussed this before, no? If it is low, both are low, it is double S, SLE and shunt. And then infective endocarditis and mesangial proliferative.
Yes, and messenger proliferative in
Okay.
and look at this.
Okay, at any point, if we have a cause like which is non-streptococcal, no, we have to think like ANA, dsDNA, anti-GBM, ANCA, then anyway we have to refer. And then if it is recurrent nephritis. And then one more we kept for the last is family history. So one is a very complicated disease. Like we have to think of the two criteria: proteinuria and hematuria. Proteinuria we have to think of if it is significant, more than 200, or if it is persistent, that is more than 6 weeks at 50, more than 50.
Actually,
Hematuria, it is.
this is proteinuria. That is massive proteinuria.
Mm,
If massive
yeah.
proteinuria, that in that case, anytime if you have massive proteinuria, so but that means more than 200 milligram per millimole.
AGN, what is the criteria for AGN proteinuria diagnosis?
No cut mark in AGN. It only in nephrotic syndrome it is cut mark.
Yeah. Okay. And nephrotic, how much is the cut?
It was
200, no?
yeah, 2 milligram maybe.
Okay. So, now indications for referral, that is most common. Etiology wise, we discussed. Is it post streptococcal? Other than that, what else is there for AGA?
Post post streptococcal.
There are other causes.
So other causes is that is Alport syndrome, IgA nephropathy, lupus nephritis, then HSP nephritis, and others.
Acute glomerulonephritis, one cause is post streptococcal,
Hmm.
post infectious. There are so many other causes, no?
Yeah, most important is post-infectious. That is
Mhm. Okay.
post-infectious glomerulonephritis. And other cause is uh, that means HSP or lupus nephritis or IgA or Alports or hypercalciuria, familiar hypercalciuria, and
Mm.
this and good pastor disease, that is glomerular basement
Yeah.
disease. This
So basically, we will treat only PSGN. If there is any other cause, we have to refer. So
yeah,
any other
yeah.
cause.
Any
So
other cause you have to refer.
anti-GBM, ANK, any of these are positive, then we have to refer.
Yeah.
Then even this low C3 more than 8 weeks, I think it is like going for SLE kind of picture. So we refer them. Then if there is any complication of the disease, like if you have kidney injury or oliguria or hypertension, then also we will refer. And then is if it is getting problematic, like if it is massive or it is persistent, and there is hematuria, which is lasting more than 2 years if it is micro, and more than 2 weeks if it's macro, and again if there's family history of glomerular disease, all these are indications for tertiary referral.
Hmm. So proteinuria, there are two 2 point. One is significant proteinuria. That means urine protein creatine ratio is more than 200. In that case, you have to refer immediately. But if
Yeah.
microscopic proteinuria, uh, persistent proteinuria, in that case, protein level is low. That means more than 50. But
But then
it more
yeah,
than,
but
if
it's
it is
more than two.
if persists for more than six
Sorry,
weeks. Okay.
6 weeks, that's right. Yeah, 6 weeks.
When it is more than 6 weeks, then you have to refer. Another point is
Mm.
yeah, another point is hematuria. So proteinuria, then hematuria. Hematuria also 2 point. One is gross hematuria, another is microscopic hematuria. If it is microscopic, in that case more than 2 years. But if it is gross hematuria, in that case it is low, but less time, because it is gross hematuria. In that case, 2 week. So if it is microscopic, in that case, up to 2 year, you can wait. But if more than 2 year, you have to refer for microscopic. But if it
Yeah,
is
what's that microscopic cutoff? 5, 5
microscopic,
RBC, something like that.
no, microscopic and macroscopic,
In centrifuged,
and
something was there, no?
five, yeah, 5 or 10. This, oh, we have to read again. Basic.
Mm.
Yeah, it is in your Bagga, that is Srivastu. Na Bagga pediatric nephrology book.
I have no books with me. I have nothing
Oh,
with me. Right.
yeah. We read it, Bagga, Indian writer. Is
Yeah, yeah, he's an Indian only. Yeah.
okay, so then proteinuria, hematuria. Now come to the BP. So if BP is high, then you have to refer. Then complication is BP and AKI. If it is AKI or oliguria, then you have to refer.
No,
Uh,
proteinuria, we need to remember persistent. If it is like P is looking like 6 only, no. So we can remember persistent proteinuria means more than 6 weeks. It's ulta of P,
hmm,
kind of ulta of P.
ulta.
So don't confuse with that 2 2. 2 2 is for hematuria. The 6 is for proteinuria.
Hmm. Two week and 2 year. So it is easily remember. If
Mm.
2 week means massive protein, macroscopic hematuria, that is visible hematuria. In that case, low time duration is low. But if it is microscopic, in that case, 2 year, long time. Okay, two and
Mm.
say ulta P. So it is
Yeah.
persistent proteinuria, and if it is grossly proteinuria, in that case you have to refer it immediately. Another thing is complication like AKI and hypertension, and then low C3 more than 8 weeks. Low
Other diagnosis. Other
other
than
diagnosis,
PSG.
yeah, other diagnosis, and family history.
And with the recurrent.
Family history. These are these three things, and recurrent nephritis. Same thing,
How do
Yeah,
we
there are
recurrent.
diagnose
4 points in the diagnosis, right? 4 points. Low C3,
Yeah,
positive ANA, DPS, DNA, family history, and recurrent nephritis. These are 4 points that point towards
yeah.
the other diagnosis.
Other diagnoses are different thing.
What is recurrent nephritis defined as? Because
Recurrent
here I
nephritis,
can 2 years.
yeah.
In hematuria, we can wait up to 2 years. So, what is their definition of recurrent nephritis? Is it mentioned anywhere, or is it something that nephrotic?
No, no, I don't think so. I don't think so. There's some exact definition that how many
Mm,
episodes in a year or so. Is there any,
I think
Dr. Abhay?
no. For nephrotic, there is. I don't know about nephritic. So, this thing we can
No,
wait until
nephritis.
for
Mm.
hematuria microscopic to clear. So, what would they mean by recurrent nephritis? Is what I'm trying to find out.
Yeah, maybe the macroscopic hematuria to be settled. And if the
Mm,
macroscopic hematuria come again, because in IgA nephropathy, when we see the patients in IgA nephropathy, it is the macroscopic hematuria that we are talking about. That is the recurrence.
mm, mm.
Mm.
Yeah.
So that maybe the recurrent nephritis they're talking about, the macroscopic hematuria.
Mm, yeah.
Because it resolves in 2 weeks.
Recurrent nephritis also other diagnosis because post streptococcal it never recurrent.
Yeah, it is
Yeah.
another diagnosis like IgA nephropathy
IgA nephropathy or
and
Alport syndrome. Yeah,
yeah,
other
Alport.
diagnosis.
What was the
So it's
difference
basically
between about IG and Alports? Can you remind me about that hearing and vision was IgA nephropathy and Alport? Which one was that
Alport.
familial one and which was
Alport
that?
Alport is hearing and vision, and IgA is Barzer disease. It is only gross hematuria, hypertension. This thing.
They
Alport is
both are familial.
both
They
are
both are
Yeah,
familial,
which
right?
was the one
Yeah.
X-linked? Yeah, yeah, there was one X-linked autosomal dominant in all of that, right?
yeah.
Which one is that?
Alport is
Alp.
X-linked, then autosomal recessive, but mostly autosomal dominant. AD is most high. Highest test is
Okay.
AD, and rest of the percentage is X-link and autosomal recessive. This.
Okay.
So basically, indication for tertiary referrals are proteinuria, hematuria,
Hmm.
complications, and other diagnosis.
Yeah.
Right? These are four. So
Hmm.
we can just in proteinuria, it is significant or persistent. For hematuria, it can be macroscopic or microscopic. For complications, it could be acute kidney injury or hypertension. And for other diagnosis, it could be family history, recurrent nephritis, low C3, more than 6 weeks, and positive ANA, DS, DNA, GBM, ANCA.
Okay,
Okay.
family history positive in which one?
Alport.
Okay, it's only Alport, huh?
Alport and IgA nephropathy as well sometimes. It's also familiar. I don't know. Am I right about it? I guess.
Okay. Hmm. So this is clear, na?
Yeah.
Okay. So
So do they ask us these questions? Like, what are the indications of tertiary referral or
yeah.
in these?
Yes. If you have a case that is history, so history is a long case, like long case. So
Okay.
when they ask your treatment, then follow up, and then they can ask you. This is history is the only
Other
place
questions.
where they can assess your knowledge, and they can
Okay.
ask everything because
Mhm.
use time it is 9 minutes per cross.
Okay. Okay.
Okay, so these things are we read for AKP, but we again forget. So normal C3, C4 is IgA nephropathy, then ANCA positive and HSP. And low C3 but normal, it is C3 is low but normal C4. It is post-streptococcal. It is also one type of glomerulonephritis. Both are low in SS, SIM, SIM card. SIM for
Both are low in start. Okay.
SIM card low, that is SLE and shunt nephritis, infective endocarditis, and messenger proliferative glomerulonephritis.
Okay.
Okay, so
And
okay, so now discharge and follow up.
so this is easy. BP is normal, renal functions are normal, and urine analysis normal. Normal urine analysis, this means
Normally,
I think permissible microscopic hematuria maybe up to 2 years is permissible maybe.
2 weeks.
2 years, no? Microscopic hematuria.
microscopic is 2 year.
Yes,
Macroscopic is 2 week. Macroscopic means you can see bleeding in necktie. That means urine is coca color. So if any patient having coca color urine for 2 weeks, that means it is more alarming. So it's a big issue. So they will go to the specialist doctor or higher center. But if it is microscopic, that means necktie you have found nothing. So only it is microscopic. So in that case, patient may delay or doctor can wait up to 2 years. Then you have to refer. Clear?
Yeah.
Okay. So SIM, we remember SIM both cases and check it. And normal is IgA, ANCA positive, and HSP. Normal is IgA, HSP, and ANCA. Okay. Discharge means normal BP, normal renal, and normal urine. Not receiving antihypertensive treatment. Okay, so
I just forgot what was the shunt nephritis? Shunt nephritis.
shunt nephritis. Oh yeah, I also forgot shunt nephritis.
Remember this and this one, but I forgot what was shunt nephritis.
what are we studying tomorrow? I have to leave.
Acha. Okay, tomorrow. Tomorrow. So we can continue renal.
I think, yeah, we can continue with histories, I think.
Yeah, history.
History and
yeah, history has nephrotic syndrome. Another history. It is written in all book.
First, all the renal cases. Can we finish first? Then?
Yeah. That I also told you.
Okay, then nephrotic tomorrow, inshallah. Nephrotic.
Okay, nephrotic,
Yeah,
but we
I
have to
think
read
would be.
a Haas. Uh,
I just, yeah. Mm.
we need to discuss about Haas, or it's a homework. IgA nephropathy, IgA nephro, then Alport and
What all
lupus.
topics in the discussion? Since which topic did you start?
It's a hematuria.
You all started with hematuria?
Yeah,
Okay, okay.
hematuria. So these things are homework. You can read yourself. This
Along with nephrotic.
yeah.
But these are basically hematuria, na?
Yeah, this is
Hematuria and
for
edema.
hematuria. Yeah, hematuria. Did you have hematuria?
In nephrotic, it would be like edema. We have to study
Yeah.
edema and
Or tomorrow we can study
infection.
Haas. These topics we can finish this. In that case, if we can do, yeah, nephritis is finished. That means glomerulonephritis is all causes of glomerulonephritis is finished.
Okay, so where should we study these from? These are not in pediatric guide.
Yeah, pediatric guideline. I think Haas is there, and Haas is just after that. This is Haas. Haas is here, and then IgA nephropathy. We can read it from what uh, Nelson, or
Survival guide. Okay. Is it
I think I have a note from Nelson. I don't know here it is present or not. Written nephrology. Yeah. I think yeah. Yeah. This is hematuria, right? Hematuria. This is evaluation history. This is Alport. We can read it from this Nelson note I made during my FCPS.
Okay, then inshallah tomorrow.
Okay, yeah,
Thank
and
you, guys.
On your FC, you got FCPS, no?
yeah.
Congratulations once again. I think I sent a message, but yeah, in person I didn't. Congratulate you.
It's a long time, 4 years ago.
Mm. Hey, 1 year ago. I mean, I thought that I saw it recently somewhere.
Oh no. It's 4 years, 2021.
Okay. So FCPS is it? What is it equivalent to? Like, what
Your
is it
DNB,
like? What? Okay,
and MD
okay.
equivalent.
Mhm. Right. Okay.
But Dr. Mariam, she has also FCPS.
Yeah, because I know both of you cleared, so I thought this is some additional thing that you took. Okay. I know that you all have cleared. You both have got MD in pediatrics already. So I was wondering whether you got something extra, like they do this extra things, no? Something like that, I thought. Okay.
And you have DNB, na?
Yeah.
DNB is same thing of MD or what?
Yeah, it is equivalent to ND, but the thing is a little bit change difference in the institution, and like it's mostly like tertiary care, what this one, private hospitals or semi-government hospitals rather than complete government hospitals. So it is that way different, and the exam is also different because our exam is will be held in a different state altogether, and it will not be in the same center or same state. We have to travel to another center.
Oh.
So some small differences.
And your training was 4 year or 5 year?
For pediatrics is for 3 years.
Okay.
You have training for how long?
Oh yeah, our time, it was 4 year, but
Oh, that's
Dr.
nice.
Mariam maybe 5 year, because nowadays Bangladesh also 5 year, FCBS for 5 year, but our
Okay,
time
the
was
entire training is for 5 years, is it?
eh? What?
And the entire pediatric training is for 5 years?
Yeah, for me it is 4 year, but nowadays it is 5 year.
Okay, that's nice actually. You get to spend more time, no? Mm.
I have 4 year training certificate, but
Right, right. For us, it is 3 years.
oh yeah, 3 years is difficult, because
Yeah,
in
it is.
many many country they ask for 5 year training.
Uh-huh. Yeah, I think it is good enough to have 5 years. Like 3 years, it's not enough actually. I don't know. It might many people might have different opinions. Mm.
Okay, so tomorrow,
Mm.
inshallah.
Okay, doctor. So this one, will you put it in the group so that we read up?
This one almost
Mm.
okay. I will
Yeah, this yeah.
start. Okay.
So tomorrow's is nephrotic, no? You have nephrotic as well for this, or it is
Uh,
only nephritis?
first we'll discuss this, then we'll start nephrotic. I
Sure,
think
sure.
difficult. It will be difficult after finishing us and all things.
Yeah, we'll make a table so it will be easier for us to recollect also.
Hmm.
Okay. Okay, then.
Okay then.
Tomorrow. Okay, thank you.